that this is a new program that we started, that I'm the director of the Parkinson's Wellness Project. My name's Susan Lust, and we started this PWP MD Lunch with Your Doctor because we felt that it was a venue for people to come together and ask their questions and have the doctors choose a subject that they love to talk about. So each time we have one more this week, and then we have a few more in November, and we'll continue them on through the next year. So today, our topic is medication matters, and we're going to hear all about it from Dr. Shahed. I'd like to introduce you to Dr. Shahed, and then I'll introduce you to our first speaker, Taryn. So hold on a second. Let me first say, what screen are you going to put on the first screen? We couldn't do this without our sponsors. So I do want to thank AbbVie, Kaiwo, Kieran, and Acadia for letting us share this program with you today. Now, yes, Dr. Jimenez Shahed is an associate professor of neurology and medical director of the Movement Disorders Neuromodulation and Brain Circuit Therapeutics at Mount Sinai West. That is a tongue twister, Dr. Shahed. Yes, and we are glad that you're here because you are a transplant, and we're so happy to have you. After completing her undergraduate degree at Washington University in St. Louis, Dr. Shahed received her medical degree from Baylor College of Medicine and neurology residency training at Duke University Medical Center. She then completed a fellowship in movement disorders at the Parkinson's Disease Center at BCM. And her research interests lie in investigating the intraoperative neurophysiology of patients undergoing deep brain stimulation. She currently serves on the Science Advisory Board of the Davis Phinney Foundation and the Medical Advisory Board of the Tourette Association of America, and has chaired the Medical Advisory Board for the Houston Area Parkinson's Society. She served as a principal investigator for the industry-sponsored and investigator-initiated clinical trials and has authored several papers and books. She is a rising star, and we are thrilled to have her. She has had received many awards, and we are so grateful that she's coming to us from Mount Sinai West right now. We will hear from her in a little while. I just want to tell you also that Dr. Shahed also offers telemedicine appointments and sees people in Florida as well as at Mount Sinai in New York. So before we hear from Dr. Shahed, I want to introduce you to our first speaker, who will just give us a little appetizer. Taryn Colon. Now, Taryn shows people that there are better ways of eating, resulting in people being less depressed, overweight, tired, and bloated. Her own personal experience of transforming her health motivated her to establish the Transformational Clinic in 1998. Taryn looks at a person as a whole being and not as a series of symptoms that have to be treated. She focuses on nutrition, good eating practices, exercise, and mental health. She's based in Fairland, Johannesburg, South Africa. She is a functional medicine certified health coach. And before we hear from her, I just want to again thank our sponsors today, AbbVie, Kaiwo Kieran, and Acadia, because without them, we wouldn't be able to bring you these programs. And one other thing that I'd like to tell you is that our questions, we must restrict our questions to general information related to the talk, and please contact your physician for specific diagnostic and treatment questions. And now I'd like to introduce Taryn.
Hi, good evening. I'm going to continue from our talk last week, which is to stabilize our blood sugar levels. But one thing with Parkinson's, we've got to understand here, when I talk tonight, it's very general. You need to contact your own dietitian, nutritionist, or contact me directly rather than address all of these issues here. So the big thing with Parkinson's, we've got to cover so many things with nutrition. We've got to cover possible malnutrition, bone thinning, osteoporosis, dehydration, constipation, stabilizing of your blood sugar levels, and also interactions with medications, apart from L-Dopa, but your blood pressure tablets, you may be on blood thinners or anything like that. So everything is very personal. So tonight it's quite general, but I'm going to cover a lot of things all at once here. What got to realize is that not one diet or one program fits all. What works for you may not work for your colleague or your friend or somebody else that you know with Parkinson's. And I'm going to cover tonight, last time I covered it more on protein side, but this time I'm going to cover more on a plant-based eating program and how to get in as many colors and how to get in as many greens in your diet as possible. And what I try and teach my clients is that to stabilize your blood sugar levels, that there are 2 times of the day that I found that work incredibly well. One is your breakfast and the other is your 2:30 to 4 o'clock. Catch those dips before the dips happen, because once you're in that dip, it can take you hours to get out of that dip. And then you become angry, moody, tired, irritable, anxious, and all your inflammation gets worse. So that's why the afternoons are often much worse for people. And I want to teach you that you've got to keep your portion sizes incredibly small. Keep them so that you've got the maximum amount of nutrition in one bowl. If you have a cracker, put something on top of that cracker that offers nutritional value. Remember that if you can only eat a small amount, make sure it is the best that you can possibly put into your mouth. Don't just eat because you can eat, or I'm just going to open up that packet of biscuits, or I'm going to do this. Put value into your body. That is extremely important. And some of the vitamins and minerals that are extremely lacking in Parkinson's are your vitamin K's and your calcium and your vitamin D's and your magnesium. And you need these to sleep. You need them for building bones. You need them to be able to relax. And so what I'm going to go through now is different ways you can actually get magnesium and calcium and vitamin K into your system with regard to plant-based foods. So if you take, for example, magnesium, which is actually needed for over 300 functions in your body, and relaxes you at night, relaxes your muscles, it helps you build bone. You can find it in so many places that you don't even realize. So for example, buckwheat, almonds, cashew nuts, Brazil nuts, all your beet greens, your coconut meat, your spinach, your collard greens, your avocados, your parsley, your brown rice, and all your herbs. Please do not discount herbs. Herbs are unbelievably nutritious, and people forget about them. Rosemary is a fantastic anti-inflammatory. A lot of people with Parkinson's have gut issues. They've got candida, they've got bacteria, and you can actually use your oreganos and your thymes and things like it in your smoothies, chop them on your food, and they all have a medicinal value and they all have benefit. So if you look at calcium, where can you get calcium in your plant-based foods? First of all, you can find very high levels of calcium in fish, for example. I'm just covering that for 1 second. Sardines have almost 4 times the amount of calcium in them than actually a glass of milk, for example. Tofu, if you are allowed to have a little bit of protein, especially in the beginning of your stages of being diagnosed, tofu is great to put a tablespoon into a big glass of green smoothie just to stabilize your blood sugar levels and also just to give you a little bit of protein and to fill you up a bit. But again, see the overlap. Collard greens, turnip greens, parsley, watercress, beet greens, olives, buckwheat, broccoli, herbs. Again, what are we finding? An overlap of calcium and magnesium in the same vegetables. Vitamin K, you of course can get it in your your animal-based, and then of course your plants. Listen to the overlap. Turnip greens, broccoli, lettuce, watercress, spinach, green beans, and again your herbs. So you could actually put the maximum amount of nutrition into one bowl or one glass of smoothie just by putting in a couple of these vegetables into your plate. And vitamin K is needed exceptionally for your bone building as well. And so what I want to say here is that try and make sure that the food that you eat is not full of brown, yellow, and white, because if you're eating a lot of brown, yellow, and white, you actually have got very little nutrition going into you. You want to fill your bowl with an incredible amount of color. So you will find some of the recipes. I don't know if Susan has actually posted some of the recipes, or we need to post some of the recipes, but one of the things that I do recommend to my clients is a green smoothie. And you may not like it in the beginning, but you do get to enjoy it if you make it properly, and I'll give recipes for that. But this is one place that you can put a pile of greens into your blender, blend it down. You can have a massive pile of greens and you blend it down into a small amount. And you cannot eat that amount of greens in a day, but you could actually drink it. So if you had to put in some collard greens and you put in some beetroot leaves and you put in maybe some spinach, or you put in some kale, some broccoli, I know it sounds awful, but actually it does taste really nice. Some lemon, some ginger, a slice or two of avocado pear, doesn't have to be a lot for the fats, and you blend it up. And you put a lot of water with that, so you're hydrating at the same time. And you have a glass of smoothie either as a meal or part of a meal. And you could make enough to last you 2 days. Don't worry about it being fresh every day. I promise you, you will still keep the nutrition in it. You can even make them ahead of time and actually freeze them. And so you take them out as you need it. So again, you're getting your calcium and magnesium, your vitamin K, all in one glass, and it's easy then to swallow down and much easier to absorb. And then, of course, other recipes we can look at are your, if you're going to have a salad, make it into the best salad you possibly can. Chop up your cabbage and your spinach and your parsley and your oregano and your little bit of avo, and if you want a little bit of beans and lentils, if you're allowed, and you make that salad into the best you possibly can. And remember, you can also repeat the same meal in a day. You don't have to find something new each time to eat. You can, if you ate something at 11 o'clock and you want to repeat it again at 2 o'clock, that is okay. So again, maximum amount of nutrition. Also chop everything up finely, grate everything so it's much easier to chew. I don't like my clients to really have too many snacks in the day. I like them to keep their portion sizes the same, rather a very small portion frequently throughout the day to stabilize their blood sugar levels. By the way, I must actually mention this before I forget. One of the things is that constipation is a very big thing with Parkinson's. And other than taking laxatives, one of the veggies that works incredibly well is actually beetroot. So if you want to get your tummy working, it's also high in a lot of nutrients, including iron. You could then put a raw beetroot into a blender on its own with maybe a little bit of lemon, ginger, and you blend it with water and you drink a glass down. It really just helps your tummy work. It's a fantastic laxative. You could make a whole lot in advance and you put it in the freezer. And so when you need it, you just take it out. I'm all for doing prep. I spend a lot of time with prep with my clients because I deal a lot with autoimmune diseases. So they have days where they're not able to actually get up and do stuff. So they go to their freezer. They could take out their apples alight. They could take out their hot toddies. They could take out all of your beetroot drinks, and you don't have to stand and make them. And so you could even add a beetroot to your smoothie so that it just keeps that stomach going. That fiber is what we need. Not only rice and crackers and things like that. Your best form of fiber is actually in your vegetables. So some of my recipes will be like your no-bean hummus, which is made with baby marrow, my tabbouleh, which you could make with rice, and my soups. So I've got the cough from Susan, which means I have to learn.
Oh, did you notice it? Oh, sorry. I didn't mean to be so obvious. I think what we'll do is we'll take a couple of those recipes and we'll put them on our website under the Chef's Corner so everybody could see them, because you're talking a lot of different recipes. And I know this sounds new to everybody, but it's good. It's good stuff. So we're going to have more time with Taryn each PWP MD lunch with your doctor that we have. So thank you for your appetizer. And and remember that 2:30 to 4:30 time, that blood sugar drop, that's very key. Rather than the coffee and donut, which you told me, Taryn, right? Rather than the coffee and donut, go for something with protein and color.
Yeah.
So, okay, thank you, Taryn. Thank you. So, Dr. Shahed, are you ready for us?
Yes, I am ready. If you're ready for me.
Yeah.
Let me get this share screen going. Hold on one second. So you have to tell me, like, I'm gonna do this now. Does the whole screen come up now?
Yes.
You can see the, okay, not the one with the small slides off to the side.
Yeah, no, we see the small slides off to the left and we see medication matters in the middle.
Oh goodness. Okay. Let me stop. Sorry, that's not what I wanted. Let's put it in. Sorry, give me 1 second. I just want to not be distracted by the
Sure. No worries.
by those things. So let's try again. Let's try putting it on screen.
Now
How
remember,
about now?
yeah, now we just see your card. Yeah.
Okay. All right. Good. Okay. Go ahead. What were you saying?
I just wanted you to remind everybody that they can ask questions as.
Oh,
you-
sure. Yes. Okay. So Taryn, thank you for that appetizer. It was sounding very delicious and was making me very hungry. So I'm sure that there are some really great recipes that that Susan will put up there and people can enjoy. So for this talk, and again, Susan, thank you for inviting me and for the introduction. I wanted to focus a little bit on medications and walk people through some of the reasoning behind medication selection and recommendations that your doctors might make, and to give you a little bit of insight, if you need it, into kind of what these medications do and kind of how they all work together and why we might use them in certain situations in patients with Parkinson's disease. And as Susan was mentioning, I'm happy for this to be an open discussion. I may need some help monitoring the chat if people are putting questions in the chat, but if you do have a question, I'm happy to field it through the course of the presentation. And if we're kind of dragging on a little bit, then I might ask for some of those to be deferred to the end. But feel free to chime in if there's something that I'm saying that warrants clarification, or if you have specific questions.
Sure. We'll read it in the chat for you. Yeah.
All right, thank you. Okay, so this is how we'll kind of progress through this. We'll talk a little bit about treatment goals and approaches, then we'll talk about medications that are commonly used. And if we have time, we'll just kind of review some of the pointers for effective communication with your physician. So what are some key concepts in Parkinson's management? Well, when we are using medications for treating Parkinson's disease, obviously one of the main reasons that we do that is to help for motor symptom control. And whether that's tremor or stiffness or slowness or difficulties with walking or balance, we are hoping to help patients maintain their functional independence in regards to any work that they're doing, if they are engaging or enjoy certain hobbies, or if there are leisure activities that they would like to continue performing. We also have built into that a concept of maintaining quality of life. And so we know a lot of mobility is related to quality of life features. We want patients to improve or maintain their social functioning. And there's certainly many patients who might be embarrassed by their symptoms. And so having optimal motor control may be helpful in ensuring that they feel confident in going out and doing the things that they enjoy. And as many of you know, levodopa is the gold standard of treatment. And that's where kind of a lot of, like, if you understand how levodopa works and what it does, then you kind of can wrap your head around a little bit about the other medications and why we might need to use them in combination. And so for those of you who have seen the movie Awakenings, this is kind of the story of levodopa and how it was sort of discovered in the treatment of Parkinson's disease. Now, there's a whole host of other treatment options in Parkinson's that address the non-motor features. So these are things like bladder or constipation, as we were just talking about, blood pressure issues. We're not going to get into those today, but those are certainly reasons why we might choose certain medications or recommend things that are potentially not even on the list of medicines that we're going to talk about today. When we choose the medicines that we are recommending for our patients, we often have in mind the concern about minimizing long-term complications of those treatments. And we'll talk a little bit about what that means. And just realize that despite all the stuff that we're going to talk about today, there's no single correct way to treat Parkinson's disease. And so what I might recommend to one patient might be different from what I recommend to a different patient, even if we're trying to manage the same symptoms, because we're really individualizing our therapies for each patient and whatever problems they're having. Now, I just want to mention a word about disease modification and neuroprotection. Although those are things that we would like to achieve, there really is not any medication that currently does that with absolute certainty. None of the treatments that we're going to talk about is curative of Parkinson's disease, and no treatment really clearly is shown to slow the progression of disease. Thankfully, that is the major focus of a lot of research and many new studies and clinical trials that you might be aware of, whether those are invasive therapies or just oral medications that you might take. So there's a lot of active research going on in this area. We just haven't quite gotten there yet with what we have available. So this is a slide that I like to go through just to describe the way that Parkinson's changes over time. And you can roughly kind of break it down into early Parkinson's, kind of moderate symptoms, and then advanced symptoms. And when patients are in kind of these early stages, they tend to have mild symptoms. They can still be quite independent. They might have been started on a medication and are experiencing what's sometimes referred to as the honeymoon period, where it kind of feels like you don't have any Parkinson's symptoms at all. And really during this time, the medications control the symptoms pretty well. As patients get into those moderate stages of Parkinson's disease, they may start to have some of the complications of these medications, where they start experiencing the fluctuations in symptoms, where they have on times and off times. But if they have them, they're pretty mild. And for the most part, patients are able to get through those pretty well. But this is also the time where patients are noticing that symptoms are affecting their daily functioning, and we often need to add additional medications. Now you see here in the moderate stage, I've kind of broken it down into two parts. So what we just talked about was kind of, and don't quote this and start telling people that this is what's out there. This is like the world according to Dr. Shahed. So just keep that in mind. But in the more advanced kind of moderate stages, patients are experiencing more of those obvious fluctuations. They may start experiencing those dyskinesias, which are involuntary excessive movements. And usually this is the stage where patients are really requiring combinations of levodopa and what we call adjunct treatments to help that levodopa work better. Then finally, in the advanced stages, this is sort of the part of Parkinson's that gets a little bit harder to treat because patients are experiencing complications like gait freezing or falls. This is a time when medications are not quite as good at controlling all the different symptoms that patients are experiencing. People might be aware of increasing disability or have dependence on others. And there may be, if the patient is experiencing it, the cognitive decline that was sometimes associated with Parkinson's disease. So that's kind of where kind of the progression of the spectrum of Parkinson's. Obviously, individual patients might have different sort of trajectories along this course. But generally speaking, this is kind of what we expect in Parkinson's disease. So what are these medications supposed to do? Well, we've talked about this already. Medications treat the symptoms of Parkinson's. So they're there to help you move better. For a lot of people, that also comes along with helping them feel better. And don't discount the part of the Parkinson's medications that really help those non-motor sort of feel good, have more energy, better mood kind of effects, because they definitely are there. And again, we've talked about how treating symptoms appropriately and specifically the motor symptoms can help patients continue doing the things that they like to do. Again, as a caveat, these medications are not curing or reversing Parkinson's. They're not slowing down the Parkinson's progression. They generally don't, and this is kind of a good point, they don't interact with other medications that you might be taking. I get that question a lot. And certainly there's not really any evidence that the medications we use to treat Parkinson's make the Parkinson's itself worse. So they're really there intended to kind of help control the symptoms and help keep you functional. So, I mean, along with those good effects that we are looking for, there certainly can be some drawbacks to taking Parkinson's medications. And these are some of the things that I often hear from my patients. They're concerned about side effects. And when we talk about sort of the collection of dopamine related medications, these are the common side effects that are possible: nausea, dizziness, sleepiness, hallucinations. We certainly don't want to put somebody in the situation where they're having to deal with those side effects. So it's important to recognize what they are and to have that kind of open communication with your physician to say, hey, I'm on this combination of medicines, but I'm really feeling quite dizzy a lot of the time, or I'm quite a lot more sleepy than I used to be, and have that conversation so you can adjust your treatment regimen. Other patients have definite concerns about cost. And as we know, it's great when new medications become available, but sometimes they're hard to get because of the insurance coverage and all of those kinds of things. So we do want to be mindful of that. And so those are sometimes concerns that patients might voice. The other sort of drawback that people often are concerned about is the development of long-term complications. And I don't really want to take this medication because I'm worried that down the road it's going to give me the dyskinesias, or it's going to give me that wearing off effect. And while those concerns are definitely ones to be aware of and to be cognizant of, and sort of to maybe even think about or plan ahead for, they shouldn't necessarily be completely closing the door for you in terms of whether you are willing to try that medication to see whether it can help you sort of feel better today. And I think that's really sort of the balance that we have to think about when we're deciding when it's the right time to either start or adjust medications. We want people to function well today while also being mindful of some of these other concerns that people have. So when symptoms are bothersome, either because they're embarrassing, they're interfering with function, maybe they're causing difficulties with daily activities or hobbies, those are times to think about, are there medication changes that can really help with these issues? It's often a very personal decision, as we've talked about, and different people might have different thought processes on what they want to do or how they want to do that. We do know that people who start medications earlier or try to get that sort of head start or kind of think ahead in terms of managing their symptoms tend to do better. So it's often a good thing to think about doing. And really what I would urge patients to do is to consider how bad is the trade-off of not making a medication change or of not starting a medication. So which symptoms that you have are you willing to live with? Is there any kind of risk of personal harm or injury by not taking those medications or changing those medications? Another thought to really think about is, what are you trying to accomplish now? And are you having trouble doing what you like to do because of your Parkinson's disease? And then lastly, and I think this is probably one of the more common conversations that I have with patients who are hesitant to either start or to change their medications, are you willing to sacrifice how you're feeling or functioning today for what you're worried might happen in the future? And I think what you'll see as we go through this kind of list of medications is that there are many options, many ways to combine these medications to try to get the level of symptom control that you need. Okay, so then I think the next part is just getting into what are some of those long-term complications of Parkinson's treatment. So we talked a little bit about the motor fluctuations and the off times and the on times. Off times are usually a period of relatively poor overall function when there's more Parkinson's symptoms present. So people might feel bad, they might be anxious, they might have pain or muscle tightening. It might be that they're slower and that it's harder for them to move. There might be more gait problems. These are usually what we call off symptoms. Then there is the on period, which is a period of relatively good overall functioning and mobility. The Parkinson's symptoms are better controlled. People generally describe feeling better, the mood is good, there's less pain, they're moving easier and faster, tremors, walking, balance, all of those things are under better control. Now, as Parkinson's progresses, patients definitely can start to feel like these medicines are kicking in or wearing off. So it becomes very important to start thinking about, if you're in that situation, how long does it take for my medications to kick in? Most patients will say that it takes about 20 or 30 minutes, but as time goes on, it may take longer. Another question is, how long does each dose of medication last? So now I've taken my medicine, I've waited my 20 minutes, if it kicked in, am I going to have 2 hours of good time or 5 hours of good time? When patients first start medications, they might get up to 7 to 8 hours and it might feel like they don't even have any of these problems. But as that disease progresses, this time interval gets shorter and shorter, and is sometimes the reason that we need to add combinations of medications. Another way to think about these fluctuations is how good are your on times? And along with that, how bad are your off times? And are they in that range of symptoms that are continuing to cause problems for you? And if so, then maybe that's something that can be addressed by a medication adjustment. Now, this return of Parkinson's symptoms when medications wear off is related to falling dopamine levels. And one of the challenges here is that those off periods can be pretty predictable at the beginning, but then as time goes on, they can become quite unpredictable. So some patients may experience this feeling of delayed on, whereas they used to know that it would take 20 minutes for the medication to kick in. Now it might take an hour or sometimes even more in certain situations. Or they might have this experience of the medications never kicking in. And so these are more down the road, but these are some of the problems that may arise and which will require attention to how those medications are being given, what combinations of medications are being given. Another long-term complication is the dyskinesia. So these are those twisting, writhing, involuntary movements that usually happen when levodopa levels or dopamine levels are higher in the brain. And this isn't really a true side effect of the medication. If you gave Parkinson's medications to people who don't have Parkinson's, they're not going to develop these dyskinesias. What it really has to do with is the way that the brain in a Parkinson's patient, a Parkinson's brain, can actually handle the medications. And when you think about the dopamine cell loss that happens over time in Parkinson's disease, it's actually that loss of those cells that makes it harder for the brain to be able to handle the changes in dopamine levels that come with taking these doses repetitively throughout the day. So it really has to do with a combination of the medications plus the underlying Parkinson's disease. And so I don't really consider this a true side effect necessarily. It's really just a challenge that we have with managing these medications over time. Go ahead, Susan, is there a question?
That's why everybody responds differently, because they all respond to the changes. So not everybody is going to get dyskinesia.
Right. Yeah. So it might be that certain patients get dyskinesias very easily. It might be that other patients never develop dyskinesias. And that's the last bullet point that I have here is what are those risk factors for getting dyskinesias? Usually we think about people who are younger, people who are taking higher doses of medications, if patients have already started developing the wearing off effect from their medications, and actually patients with lower body weight. We know through clinical trials and studies that these are some of the risk factors for developing the dyskinesias, but it is different for different people. You're absolutely right. And so, you know, we just have to be vigilant and have to be knowledgeable and have to act according to the situation that we are experiencing.
Well, that sounds like weight gain could be a good thing.
Yeah, so weight gain, not necessarily for the purposes of handling medications better, but I think people with sort of those smaller body frames. So often, you know, what actually one of the trials suggested that women were more likely to get dyskinesias than men. And we will see that sometimes, especially kind of smaller frame women compared to a big husky man. You know, if you're looking at dose for dose, those are the patients who might be more likely to get dyskinesias.
So when you meet a patient and you look at that whole picture, you look at their frame, their size and everything, and that's how you would recommend medications also?
Yeah, I mean, I think sometimes you know, there's still a little bit of trial and error despite all of that sort of thought process. And so what I generally tend to do is to give patients kind of a dose titration schedule. So you're going to start this medication, we're going to start low, we're going to go slow, and we're going to be extra vigilant because maybe you are younger, or maybe because you are already experiencing certain problems with your medications. And when we hit that time, you know, a problem such as dyskinesia, we may or may not be surprised about it given the individual situation of that patient. So it's always best to start low and go slow and sort of see what you need. Rather than kind of piling it all on and just then being surprised that maybe there was a problem like this.
It doesn't mean that if you have dyskinesia, you can get rid of it also, right?
Right. And there are treatments for dyskinesia, which we'll talk about when we get to the medication part. Absolutely.
Somebody has a question. Can I just ask this?
Yeah. Yeah.
Husband has meds to sleep better, but it makes him drowsy all day, so he's not taking them. What do you suggest? His sleep pattern is very bad.
Yeah, so sleep is definitely an important concern. That's not really, it wasn't something I was planning on focusing on today, but we do know that when people aren't sleeping well, then their Parkinson's control is worse. So it's important to find that right strategy for managing the sleep problems. Unfortunately, medicines that you take to make you go to sleep, and so you might be more sleepy than you want to be. But the good news is there are many different ways to address sleep problems, and so I just encourage you to go back to his physician and have that conversation and say, hey, this isn't working out.
Right.
Okay. All right, so we'll keep moving. I'm going to skip this one because I think we've talked about dyskinesias now, but some of the questions, I think, focus on the pink questions at the bottom of the slide here. So some of the questions about dyskinesias: how long after each dose do the dyskinesias start? How long do those dyskinesias last? Are the dyskinesias painful or uncomfortable or disabling in some way, or are they things that you can kind of manage and don't really bother you too much? And sometimes thinking through these questions can help us decide, if there is dyskinesia, do we need to manage it, and how do we need to manage it, or how much of a difference do we need to make in the dyskinesia to make them better? All right, I'm going to skip this one because I think we've talked about these things. Well, we probably just need to get on to the medications. All right, so the next section is knowing about your medication. So the treatment options in Parkinson's can very roughly be divided into dopamine-related treatments or non-dopamine related treatments. So Parkinson's is a condition where you lose the cells in the brain that are making dopamine. And when you don't have dopamine, then you get stiff, slow, shaky, and you don't walk very well, right? So this is, I think, the common symptoms that patients are aware of. So most of the time when we are treating Parkinson's, we are doing something to either replace dopamine, we're trying to stimulate the dopamine receptors to make the brain think that there's more dopamine around, or we are preventing the dopamine from breaking down. That's kind of how we try to maintain dopamine levels or dopamine functioning within our brains. Now, there are, as I mentioned, some non-dopamine treatments that are very focused in terms of what they can do. So for example, as we'll talk about, there are some non-dopamine treatments that can be used to manage off times. There are non-dopamine treatments that can be used just to manage tremor. There are non-dopamine treatments that we use to manage the dyskinesia, as Susan was alluding to earlier. There are muscle relaxers if you're having those kinds of problems. And then certainly a whole host of other medicines for the non-motor symptoms, such as the sleep question that just came up, which again, we're not going to focus on today. This is kind of a busy table, but it kind of covers the breadth of the different kind of medication options that are available. So there are, as you see on the first column here, the levodopa, which replaces brain dopamine. There's the group of medicines that we call dopamine agonists, which stimulate the dopamine receptors. There are the COMT inhibitors, which prevent the breakdown of dopamine. There's the MAO, this is an alphabet soup, I'm sorry, an MAO inhibitor that prevents the breakdown of dopamine. There's what we call anticholinergic medicines that work on a non-dopamine way to help control tremor. And then there's amantadine, which is really the main medication that we use to treat dyskinesia. So the important part to take away from this, I don't want you to memorize everything on this table, but it's that there's several different types of medicine in each of these groupings. So we do have a pretty wide array of different medication options that we can consider in treating Parkinson's. So we're going to break these down a bit one by one. So let's go through those next. So levodopa, as we mentioned, is what we call the gold standard. So levodopa gets into your brain, it gets metabolized to dopamine. So you're essentially replacing what the brain isn't making. The hard part about levodopa is that you can't take it on its own, because if you do, then it can cause side effects like nausea or vomiting or dizziness and feeling like you want to pass out. So we always give levodopa with carbidopa. So that's why you have always those funny combinations, carbo-levo, carbidopa, levodopa, all of those things that you have seen on the pill bottles. Now, levodopa is always an appropriate therapy in Parkinson's. It's always going to help control the symptoms. The controversy that we run into is whether you should use it earlier in Parkinson's versus later in Parkinson's. And I think if you put 10 doctors who treat Parkinson's in a room, you're going to get very different opinions on what they prefer to recommend for their patients. I think it's important to just understand that it's never wrong. And it's, maybe more of a personal preference or a physician kind of preference or recommendation about when is the right time to kind of use it. As we've talked about, the motor fluctuations and dyskinesias, those are generally complications of this levodopa. And so that's why, as time goes on, people start experiencing those issues, and we then need to use the combinations of medications. Now, with any kind of dopamine medication, the common potential side effects, and these are just kind of the ones that I rattle off all the time in the clinic: nausea, dizziness, sleepiness, hallucinations. Those are kind of the common ones to be aware of anytime you are dealing with a medication that affects dopamine. All right, now there's several different levodopa and carbidopa formulations. So there is the immediate release version, that's what we call Cinemet. There is an extended release version called Cinemet CR, or some people may know it as carbidopa levodopa ER. The main difference here is that the CR or the ER formulations tend to be a little bit harder for the body to absorb. So they aren't quite equivalent dose for dose, even though the milligram strengths look the same. And so there might be reasons to use the Cinemet CR, but it doesn't always work as well as an extended release medication, just because the body can't handle it very well. And it tends to sometimes complicate the presence of the wearing off effect or the dyskinesias. Now, a better probably version of an extended release is something called Rytary. Some of you might be familiar with this. It's also referred to as carbidopa levodopa capsules. So these are the big kind of capsule medications. Unfortunately, because of the way that they had to make this version of carbidopa levodopa to get it to be an extended release, you have to take more capsules to get the same effect. So the milligram strength with Rytary is not the same as with immediate release carbidopa levodopa or with the ER formulations. There's a version called Parcopa. This is one that you put on your tongue and it dissolves. And so sometimes this is great for getting a quick on. Sometimes it gets into the system within 10 or 15 minutes instead of having to wait 20 or 30 minutes. Sometimes it's nice if you're out and about and you just want to take the medication without having to swallow it with water or a drink. It also can be particularly helpful for patients who have trouble getting the pills down because it dissolves on the tongue and then you swallow that liquid as opposed to taking the pill down. Otherwise, it's identical to standard Cinemet or standard immediate release carbidopa levodopa. Now, there is a version of carbidopa levodopa that you can use as an infusion. And this is something that some of you may be familiar with that's called Duopa. It's a duodenal infusion. We're not going to talk about that. It's more of an advanced therapy when patients are experiencing fluctuations and dyskinesias. And then there is now a version called Inbrija, which is an inhaled version of levodopa. It's an inhalation powder, and you use that as rescue therapy. So if you're in a situation where you feel like your medicines are about to start wearing off, you could potentially use this Inbrija inhaler and get back on quickly. So it's used in that way, and we call that a rescue therapy. So there are all these different formulations of carbidopa and levodopa that you can use. Any questions about that one before I move on to the next group of medication? Okay.
You can call out if you want. You don't have to write it in the chat.
Okay. So I'll go on, but if somebody does have a question, please go ahead and chime in. We can always go back. All right, so the next group of medicines is the dopamine agonists. So these are the medicines that stimulate the dopamine receptors. They make the brain think that there's more dopamine around, but it's not actually replacing the dopamine. So these are medicines that we call pramipexole, ropinirole, rotigotine, apomorphine. So there's several different kinds of these. These medications generally can be used by themselves to treat Parkinson's symptoms, or you can use them in combination with the levodopa. They are less likely to induce the motor fluctuations or the dyskinesias in levodopa, so they definitely have their advantages. And they also tend to work for longer at the receptor, so you can get longer kind of effects from them when compared to the levodopa. And they really can treat any major symptom of Parkinson's disease. It's just that over time, they might not be enough, and then levodopa is required in a combination. So again, some of the common side effects of these medications: nausea, dizziness, sleepiness, hallucinations. But this particular group of medications is more commonly associated with the sleepiness and even sleep attacks where patients are falling asleep inappropriately. So we have to be particularly aware of that and monitor for that. These medications are also more commonly associated with the impulse control disorders, which is where people may have more urges to go shopping, or more urges to gamble, or more urges to use the computer for long periods of time. And there's other kind of behaviors that fall into this category. I think it's important to remember that these are not going to flip a switch. So it's not like you start taking the medicine, all of a sudden you want to go out and buy a bunch of stuff or do other crazy things. It's a gradual process. And so so it's important to be aware of it so that if you do start feeling like those things are happening, then we kind of back off and maybe even stop the medication or switch to something else.
Is Mirapex one of those?
Yes. So the brand names for the drugs that are listed at the top, pramipexole is Mirapex, ropinirole is Requip, rotigotine is Nupro, and apomorphine has like 3 different versions. So there's Apokin injection, 2 versions, excuse me, Apokin injection, and then Kinmobi sublingual.
Okay, thank you.
So, but they're all in the same class and they're sometimes used differently, as we'll talk about here. So the Requip, Mirapex, and Nupro ones that I just mentioned, those are ones that you can use at any time, early or late Parkinson's disease, use it by themselves, use it in combination with the levodopa. Sometimes they're used as a strategy to reduce the levodopa requirements. And then the apomorphine is the one that's really used as the rescue therapy. So the Kinmobi, which goes under the tongue, or the Apokin, which you can inject in the same way that you might use the levodopa inhaler. These are used for unexpected or sudden off times to get turned back on quicker. Okay. Any questions about these? Again, if you do, just call out with them or type them up and then we'll come back to them.
Would a regular neurologist know all these details about all the medication?
You know, the idea, they should, right? I mean, if they're prescribing a medication, they should understand these things. I mean, none of this is, you know, unheard of. It's all pretty common. It's well recognized. So they should know. I always say that patients and their families are their best advocates. And so that's why I feel like it's important for patients to also be aware of these things so that in case their doctor may not have picked up on it or known that it was a problem, then they can mention them as well.
Is dyskinesia reversible?
So the question was, is dyskinesia reversible? So dyskinesias happen when you take your medications. And if you stop taking your medicines, you won't have dyskinesia. Or if you lower the dose of medications, you won't have it. But then the challenge becomes, did you take enough medicines to be on? And so that's why when dyskinesias happen, there starts to be some, you know, kind of challenges in using these medications in combination together. And we have to be very smart about how we do that.
So, you know, sometimes people, so you always have to be in touch with your doctor about what you're changing, you know,
Yeah.
if you're changing your medication.
Right. Yeah, absolutely. I mean, I think do that in conjunction with a discussion with your doctor so that you know what to expect. And that's really kind of, you know, one of the questions that you should be asking if you're getting a new prescription. What should I expect with this medicine? Okay, so then the next group is the COMT inhibitors. We're in the alphabet soup now. So these are the medicines that prevent the breakdown of dopamine. They help the levodopa act longer. And sometimes when you add these medications, you can actually reduce the amount of levodopa that you're taking. So there's definitely reasons to think about using them. We only use them in combination with levodopa. You would never use these medicines by themselves. And the main reason to do it is to reduce your off time. And as a consequence, increasing the amount of on time that you have. And so there are 3 different options. Entacapone is the one that you have to take with every dose of levodopa. Tolcapone is one that was out a long time ago, but really hasn't been used very much because of concerns of effects on liver functions. And then the newest one is something called opicapone, or it's also known as the brand name Ongentys. This is the once daily dose. It tends to bind more strongly and really reduces the fluctuations in the dopamine levels in your system. And so I think a lot of patients have to reduce the amount of dopamine that they're taking when they add this on board. But they're all, you know, in the same class. Some of them might work better for one person or another. And so it's good to know that there's different options here as well. Okay. The next alphabet soup is the MAO inhibitors. These are the medicines. They also prevent the breakdown of levodopa or dopamine. Some people have heard about the potential interaction of these groups of medications with, you know, certain diet factors or with other medications. And really, you know, I think one important take-home message here is that with these versions of this class of medication, we really don't need to have any dietary restrictions, and you can actually safely use them with any of the antidepressants that you need to use. Sometimes this question comes back from the pharmacist after we send in the prescription. So these are medicines that can be used in a couple of different ways. They can sometimes be used by themselves early on in Parkinson's to give mild symptom benefit, or they can be used in combination with the levodopa to increase the on time and help that levodopa work better. So these are the different versions. There's selegiline, which sometimes I like to use because one of the ways that the body handles this medicine is to turn it into like an amphetamine, which actually for some patients can help their energy levels, their fatigue, their mood. So that's sometimes an advantage to the selegiline. Zelapar is a different version of the selegiline, but it's the same type of medication. Azilect or rasagiline is a little bit more potent than selegiline. Some people believe that it has the potential to slow down the progression of Parkinson's. That has not been proven in any clinical trial, but there is some laboratory evidence that might be the case. And so sometimes I like to recommend this for patients when they're just initially diagnosed, just as a potential kind of way to address the long-term concerns with this disorder. And then the newest kid on the block in this class of medications is sulfonamide with the brand name Xadago. Its official indication is to treat the off time. So you really only use that one in combination with the levodopa. Okay, but they all kind of work in similar ways. Again, some people might respond better to one or the other, or there might be reasons to think about using one or the other. And so it's nice to have these different options when you're trying to get these effects. All right, I see some questions in the chat. Should we take a peek at them?
Sure. There's
okay, so somebody was asking about the carbidopa, levodopa, and entacapone. Let me go back to that. I'm sorry, I did not cover that, but that's an important point. So in these COMT inhibitors, the entacapone is the one that's been used probably the most. As I mentioned, the tolcapone or Tasmar kind of went out of favor because of the liver function test issue. But this entacapone is also known as Comtan. It can be given as a pill by itself. So I can write a prescription for Comtan and say, hey, add this onto your current medications, or it comes as a combination pill with the carbidopa, levodopa, and entacapone, all three together. That's also known as brand name Stalevo. Okay, so that's kind of a way, once you're on a stable dose of medications, if you can combine it all into one pill, that can make it easier for some patients. All right, the next question here is about timing. How important is it to be exact about what time to take your medicine? Here the question is specifically about Rytary. You know, it is important to be consistent with your medications, because if you're inconsistent, then it becomes really hard to figure out what the pattern is. So I often ask patients to be on a regular schedule and to kind of watch the clock and be as consistent as possible. If you're finding out that, you know what, 30 minutes before every dose, I'm really watching the clock and I want to be taking my medicine sooner, that's something you need to tell your doctor, because they can either adjust your schedule for you or use the combinations of medications together so you're not watching the clock that much. So I think it's important to keep track of that. And you know, if it happens once or twice here or there and you really need to do it, nobody's going to be upset about that. But if you're finding yourself really wanting to do that a lot of the time, probably means you need to change something on a regular basis. Okay, hopefully we covered what was in there. Okay, so then let's go back to our slides. Another new kid on the block is this group of medicines that we call, it's a mouthful, A2A receptor antagonist. There's only one medicine in this group. It's called istradefylline. Gosh, for some reason, I have such a mental block on the brand name for this one. Susan, do you remember?
Yeah, it's Nurians, right?
Yeah, Nurians, thank you. So whenever I come to this slide, I'm always like, what's the brand name on that one? Okay, Nurians or istradefylline. So this is a non-dopamine medication. It works with a very unique mechanism of action. It's only added to levodopa because what it mainly does is to help the off time. And then if you look at kind of the group of patients who were using this medication in the clinical trial, some of the side effects were, again, sort of the usual ones: nausea, you see dyskinesia there, but some other things kind of came into play with this one, such as dizziness, constipation, insomnia. So just be aware that some of those things have been associated with this medication. Again, the main reason to use it is if your medications are wearing off. All right, the anticholinergics, these are non-dopamine medications that work on a different brain chemical called acetylcholine. And the two main types are trihexyphenidyl and benztropine. The main reason we use these medications in Parkinson's is to treat tremor. So they're not really, if your problem is stiffness or the way that you walk or things like that, these medications aren't going to do anything for that. But if your problem is the other medicines treat everything except my tremor, then this might be a medication to consider. Now, the challenge with these medications, especially in older patients, are the side effects: dry mouth, dry eyes, confusion, memory loss. Sometimes these are more common in our older patients, and in particular, another main one is the urinary retention. So we definitely want to be knowledgeable about that and vigilant about it, and kind of take care when we are using these medications. But they can be quite effective for tremor management if other stuff is not working. Oops, this one, the build was backwards. Okay, so amantadine, as I mentioned, this is the medication that is used for managing dyskinesias. Now, amantadine is a medicine that is, I call it a dirty drug because it does lots of different things. It has a little bit of dopamine in it. It has dopamine action. It has a little bit of the anticholinergic effect, but it really has a very different chemical effect that is likely the reason why it works for managing the dyskinesias. So this medicine, this was kind of the old flu medicine. We found out that it does treat some Parkinson's symptoms. So I sometimes use this in early Parkinson's patients when they have mild symptoms, just to try to help them get symptom control without having to use the levodopa. But the main way that we use this medication is for managing the dyskinesias. And there's a couple of different versions. There's just the plain old generic amantadine. There's GoCovery, which was the extended release, which you take once at night. It actually now has 2 indications. It can improve the dyskinesia and improve the off time. So sometimes that's a good choice to kind of get 2 birds with 1 stone. And then there's another version of this one called Osmolex, which is also an extended release, but in a different way. Technically, it was just built off the original amantadine medication, and so it doesn't have the official approval for dyskinesia, but we can use it that way if we need to. Otherwise, nobody's kind of compared any of these medications together. But again, as with all the other ones that I told you, some patients may respond better to one or the other. And so again, it's good to know that we have these different options for managing this symptom.
We need a cheat sheet with all of this.
I know. Yeah, that's that table. So if anybody wants the table, you can have the table, but that's the cheat sheet with everything listed on it.
Okay, well,
we'll go back and
yeah,
I can send that to you later.
That's good.
Okay, so then this is a summary. Don't memorize this, but just shows you we have lots of different medicines that we can use at different times, and we might use them under different situations for different patients. Some are more the kind that we can use early on in the course. Others are things that you definitely wait to use later. But we do have quite a bit of different options now to treat different symptoms. All right. I'm going to stop there. Susan, our main focus was on medication. So I just want to maybe make sure that people don't have any questions about that. And I do have, I don't know what time we were scheduled to go, but I did have another call that I needed to get to. Does anybody have any questions about the medications that we went through? These were my extra slides. And then the end was just going back through sort of the stuff that I had gone through in the slides about what things to keep track of.
Can I say something?
Yes.
Yes, you spoke about anticholinergics, right?
Yes, I did.
I took one called Ditropan
Yes.
for many years.
Yes.
After 5 or 6 years on it on a regular basis, my OAB was reduced tremendously. This is before I was diagnosed with Parkinson's. This goes back.
Yeah.
Anyway, I developed MCI.
Mm-hmm.
It happened to have been at a discussion at the JCC, Jewish Community Council Center on Amsterdam Avenue, from the head people of Mount Sinai on Alzheimer's. So I went there.
Mm-hmm.
After the assistant asked about it, and I said yes. And I explained my situation. Afterwards, the head man, Dr. Mike, I don't remember his name. He was the head of the Mount Sinai Alzheimer's, which, sponsored by the NIH.
Mm-hmm.
Said to me, how long were you on it? I said, 5, 6 years. How's your mind? I said, well, my long-term memory, I'd say I lost about 20%. He looked at me and said, you are the luckiest man I've ever met. I said, what do you mean? I've been on the head of the research. You're the first person I've met who was on it for so long that didn't lose the whole memory and never got it back. Most people on an anticholinergic for 5, 6 years lose their memory, he said, and never get it back. So I think you should let people know, be very careful on that with those drugs.
Right. So the medicine that you're talking about, ditropan, is an anticholinergic. It's used for management of bladder symptoms. as you
Ditropan,
were mentioning.
Detril, and all those others.
Yeah. So those are not usually medicines that we would use for managing the tremor in Parkinson's disease. So it is a little bit different. It does work a little bit differently, but as a general rule, any of the medicines that block acetylcholine can have quite prominent for some people memory problems. And so I definitely do not enter into that treatment without having the conversation with patients. And if anybody comes back to me and says, you know what, I'm feeling like it is affecting my memory, then we stop it. So,
Thank you.
you know,
I just wanted to let people know
Yeah.
my experience, and that the head of Mount Sinai's research said, I'm the first person in all the years who has a memory left. This was about 4 years ago,
yeah.
5 years ago.
Keep up the good memory.
Yeah.
Bless my parents.
Well, thank you very, very much, Dr. Shahed.
Yeah.
It was great to hear all that. A little overwhelming. I think we all do need that cheat sheet, so we do feel empowered when we go to our doctor.
Yeah, I'm happy to send that to you. I'll do that when we're done here.
Yeah. But I want to thank Taryn again also and Dr. Shahed, and we will have this recorded. So if you want to share this with any of your friends, please, we'll have it up on our website next week. And August 26th, Dr. DeMarcita is the last of our summer lunch with the docs. So I hope you'll all join us. And again, thank you very much, Dr. Shahed.
Thank you for having me, and thanks for your questions, and look forward to meeting with you guys again.
Thank you. Bye, everybody. See you Thursday, I hope.